Good morning, everyone. It's my distinct honor to introduce Dr. Erin Kirkham as our ground round speaker this morning. Dr. Kirkham is Assistant Professor of Otolaryngology, Head and Neck Surgery at the University of Michigan. She completed her MD at the University of Chicago and her Master's in Public Health and Epidemiology at the University of Washington. She went on to complete her residency in T32 at the University of Washington and later a fellowship in pediatric otolaryngology at Seattle Children's. Dr. Kirkham's expertise is in pediatric sleep apnea. She's part of the University of Michigan's Center for Sleep Science, a member of the Multidisciplinary Pediatric Complex Sleep Clinic, and has published extensively on this topic. Her work has been supported by multiple grants through the NIH, OHNS Foundation, and ASPO, and she's been involved in the most recent international consensus statements on pediatric DICE and diagnosis management of pediatric OSA. Today, she will be sharing her expertise regarding the latest updates in pediatric sleep apnea. We very much look forward to having you, Dr. Kirkham. Thank you so much for being here.
Thank you so much for the invitation and for that introduction. I actually grew up in the Bay Area there in Vallejo, and I rotated did an away rotation with you guys 15 years ago, and I was running around after Doctors Chang, Dur, and George, who were all residents at that time. And if Dr. Goldberg is on, I just want to thank him for the letter of recommendation. It helped a lot. So with that,
I am definitely on, and it was my pleasure.
Yay, thank you. In any case, so getting into it. Yes, so today I'm going to give you guys some updates on pediatric OSA, obstructive sleep apnea. And I'll first focus on recent trials in pediatric OSA with a focus on the FACS trial, and then discuss updates in management of persistent post-adenotonsillectomy OSA, including how we're using DICE more and more to treat this, and hopefully get time to talk about hypoglossal nerve stimulation in kids. So this is the obligatory background slide, but obstructive sleep apnea, as most of us know, is characterized by repetitive breathing pauses during sleep. And it affects an estimated 6 to 15% of kids, depending on the study you look at. And compare that to asthma, where the prevalence is 5 to 9%. So it's pretty similar. We know that it negatively impacts quality of life, cognition, behavior, school performance, blood pressure, and autonomic function. And we suspect it may lead to poor health outcomes down the line for kids if left untreated. So when kids present with this, we have a few options up front. We can observe for a while because we know about 40% of kids with mild to moderate OSA can self-resolve. We can try CPAP like with adults, or oxygen by nasal cannula in younger kids. Medications, mainly nasal steroids and leukotriene inhibitors, can be effective. Maxillary expansion for kids who are candidates, that's an orthodontic procedure to expand the hard palate. But still, first-line treatment with adenotonsillectomy is the mainstay for us. So 4 randomized trials have come out in the past decade that have compared adenotonsillectomy to watchful waiting in children to try and understand the benefits of AT in kids. And the most recent was the FACS trial that came out just over a year ago, and that stands for Pediatric Adenotonsillectomy Trial for Snoring. And Michigan was one of 6 recruitment sites nationally, and I've had the privilege to be part of this study. And so I'm going to talk a bit about it. Before I get into some of the findings of PATS, I wanted to put it in context of the trials that have come before it. These trials have ranged in size from 60 to over 450 subjects. The CHAT trial was the first. It focused on school-age kids with mild to moderate OSA, and about a third of them were obese. The POSTA trial came out of Australia, focusing on preschool age kids, also with mild to moderate OSA, none of whom were obese. Then the CATE trial was a smaller trial out of Sweden that was also focused on preschool age kids with mild to moderate OSA, very few obese. And then the PATS trial, larger US study, focused on a wider age range than CHAT, so kids from 3 to 12, but specifically kids with just primary snoring or very mild sleep disordered breathing. So they had to have a sleep study showing that their breathing pause per hour was less than 3, and about 20% of them were obese. So what have we learned from these trials taken together? So focused on the trials for OSA, this graph shows the percent of subjects in either the watchful waiting group in blue or adenotonsillectomy group in yellow whose OSA resolved to an AHI less than 2. And in both the CHAT and CATE trials that presented their data this way, the resolution rate was higher in the adenotonsillectomy group. And so this is the comparison of OSA improvement between arms measured by a drop in obstructive events per hour. So the longer the bar, the greater the drop, the more improvement, the better. So in each trial here, patients experience greater improvement in their OSA in the tonsillectomy group rather than the observation group. And in PATS, none of the kids had frank OSA. So we compared groups with respect to sleep disordered breathing progression defined by a follow-up 12-month obstructive apnea hypopnea index greater than or equal to either 3 or 5. And a greater percentage of kids in the observation group definitely progressed from sleep disordered breathing to OSA than in the AT group. About a quarter of the kids in the AT group here had symptom persistence or progression compared to about half, though, in the control arm. In all 3 studies that collected caregiver-reported outcome measures of behavior, symptoms, and quality of life, adenotonsillectomy was superior to watchful waiting. However, with the exception of one measure of executive function here, the brief in the CHAT study, which did show favorable response to adenotonsillectomy, none of the studies found a difference in measures of executive function or neurocognition. So taken together, I think we can safely conclude that kids with OSA see improved events on PSG with resolution rate ranging from 60 to 80%, improvements in behavior, quality of life, and symptoms, but maybe not so much with respect to cognitive function. And for sleep disordered breathing, it's similar. Adenotonsillectomy decreases the odds of progression to OSA and improves quality of life, symptoms, and behavior, but again, not so much for cognitive function. And we're not sure at this point if it is that it really makes no difference to cognitive function, or it's the sensitivity of the test or the way that we're measuring it. Either could be true. So we collected a lot of data as part of the PATS trial. So what else did we find out? One question I really wanted to know was, can information known at presentation in clinic predict persistence or progression of mild sleep disordered breathing in the kids who are observed? So in other words, which kids should probably not be watched for a year and instead undergo adenotonsillectomy earlier? And we looked at 2 outcomes for this study. The first was PSG progression from a baseline OHI less than 3 to greater than or equal to 3. And then secondarily, symptom persistence or progression defined as a 12-month pediatric sleep questionnaire or PSQ score that was greater than 0.33, which is a cutoff for high symptom burden. So of all the kids randomized in CHAT, half were observed for 12 months without surgery, and of that group, 64% followed up with a 12-month polysomnography. That may seem a little low, but COVID happened in the middle of this trial, so that was an interesting challenge. About 13% of those kids progressed in their basically from sleep disordered breathing, mild sleep disordered breathing to OSA. So not very many, 13%. In unadjusted analysis, we found that kids of Black race had higher odds of PSG progression, and then kids with a higher baseline symptom burden. But when we attempted to do multivariable predictive modeling, it didn't really yield a set of variables that very strongly predicted progression. In terms of the second outcome measure, symptom persistence, of the kids randomized, essentially of those, the group that was observed, 82% actually followed up for their 12-month symptom assessment. And of those kids, 57% of them still had a high PSQ score, a high symptom burden. For the most part, 94% of these kids, that was persistent from a high baseline symptom burden rather than progression. And there were higher odds of symptom persistence or progression among kids who had asthma, ADHD at baseline, or home tobacco smoke exposure. And somewhat surprisingly, we found lower odds of progression among kids who had large tonsils and were observed compared to kids with smaller tonsils. And I would have expected the opposite. So I took a closer look at the data. And I think this was really driven by kids with tonsils that were on the smaller side and had a high symptom burden, really not getting better by 12 months. So there wasn't that big of a difference between groups, although these kids had some improvement compared to the others. And I think what this is telling us is that there are a lot of factors apart from tonsillar hypertrophy that contribute to sleep disorder breathing. So things like diffuse airway inflammation, non-tonsillar sites of anatomic obstruction, low pharyngeal tone, or altered respiratory physiology. And that, these can certainly play a role in kids with even small tonsils, and they may not resolve in 12 months. And so we just published a study this year on this research question. So I wanted to know, does adenotonsillectomy cause undesirable weight gain in children with sleep disorder breathing? And I got interested in this because there were some studies that came out, including a meta-analysis in 2009 that suggested that adenotonsillectomy might result in unwanted weight gain in kids over time. But there hadn't been many data from many controlled studies. So yeah, this is the paper that came out recently in JAMA Oto. And so what did we find? So of all the kids randomized, 82% of them followed up with 12-month height and weight data. And there were roughly equal numbers in the two arms. And we compared two outcomes between the two study groups. The first was change in percent BMI P95, which is a measure of overall weight gain that's normalized to sex and age. And then also this concept of undesirable weight gain. So I'll define both of those. So the change in percent BMI P95. So that's the percentage of a child's age and sex-specific 95th BMI percentile. And we use this metric instead of the more common change in BMI Z-score because as a child approaches the upper limit of BMI for age, the BMI curves that are used to calculate Z-scores are compressed so that a wide range of very high BMIs have very similar Z-scores. And this makes it harder to detect changes in weight in very obese kids. So their adiposity might increase quite a bit, but their BMI Z-score may not change that much. And so this is just an example of a child whose BMI is, off the normal CDC growth chart here, but the extended growth chart shows that their percent BMI P95 was 120% of the 95th. So when we compared this metric between study arms, we found that the absolute increase in percent BMI P95 was higher in the adenotonsillectomy group here, but there was really not a clinically or statistically significant difference between the arms. We did want to know, though, who was gaining weight in the study. Was it baseline underweight kids or kids already of normal or overweight? So this graph shows the percentage of kids who started underweight at baseline, who were then underweight still or normal, overweight or obese at 12-month follow-up. You can see that more kids in the adenotonsillectomy group improved from underweight to normal weight, but the N was low here and this was not statistically significant. The same breakdown for kids of normal weight at baseline, there were really no substantial differences between the two arms in terms of their follow-up weight categories. Very similar for kids who started in the overweight category. And in the kids who had obesity at baseline, there were slightly more of them who moved down from obese to the overweight category in the watchful waiting group. But again, this was not a very significant or statistically significant difference. Our second outcome was undesirable weight gain, which was defined as either starting at baseline normal but increasing to overweight at 12 or obese at 12 months, or starting at baseline overweight or obese and then gaining more weight over that 12-month period. Let's see here. And we found that undesirable weight gain occurred in 29% of all the kids in the study, 32% in the adenotonsillectomy versus 20% in the watchful waiting group. And this was not a significant difference. So does adenotonsillectomy cause undesirable weight gain in kids with sleep disordered breathing? I think we can safely conclude that it doesn't. These findings from PATS are backed up by this analysis that we published of chat data in sleep a few years ago, sleep medicine a few years ago, backed up by a slightly different analysis of chat data and then also data from an Australian RCT called the POSTA trial, which is one that I mentioned before. So I think this is very reassuring to clinicians, pediatricians, and families. The next and final study that I'll present from PATS asks the question, does adenotonsillectomy improve asthma symptoms in children with mild sleep disordered breathing? Because the two, conditions are very coincident in children. So this is a graph. On the y-axis here is the percent of kids who had a high asthma symptom burden. And then the x-axis shows the symptom burden at 3 time points, baseline, 6-month follow-up, 12-month follow-up. The watchful waiting group is in blue and the adenotonsillectomy group is in pink. And there were a similar percentage of kids with high asthma burden at baseline in the 8% in watchful waiting and 7% in adenotonsillectomy. So very similar when they started the study. And this remained largely unchanged in the watchful waiting group over time, but decreased down to 2% by a year in the adenotonsillectomy group. These numbers were very small, so this is, did not reach statistical significance, but suggests that tonsillectomy maybe improves asthma symptoms in kids. So I'm sure more study on that to come. So I'm going to transition now from talking about adenotonsillectomy as treatment to talking about what we do with kids who have persistent post-adenotonsillectomy OSA. This occurs on average in all comers about 40% of the time. That percentage is lower, 20 to 30% in kids without risk factors and up to 60 to 80% in children with risk factors. And those risk factors are, not surprisingly, obesity, children of Black race, kids with very small tonsils, those who have severe baseline OSA, and conditions like Down syndrome, neurologic disorders, so cerebral palsy, hypotonia, and then craniofacial disorders. And this, persistent post-AT-OSA has really, kind of started to loom large among pediatric otolaryngologists, at least to me, because I'm a sleep nerd, but, more consensus statements and more research has been done on this over the past, roughly 10 years or so. This was an expert consensus statement that the Academy put out on management of persistent OSA in kids. And then this was an American Thoracic Society clinical practice guideline that also came out. And these two papers were very similar in terms of their recommendations. So they suggest, you can use CPAP in kids, you can try it, consider orthodontic or dentofacial orthopedic treatments where appropriate. They really talked a lot about weight loss, trying weight loss in this paper. Of course, always easier said than done. They mentioned secondary surgery or second stage surgery, focusing on lingual tonsillectomy and supraglottoplasty where appropriate, and then also talked about how medications can sometimes be effective. So at Mott, we have a dedicated multidisciplinary pediatric refractory OSA clinic. And I feel so privileged to work in such a collaborative place with this great multidisciplinary team. And I think it really allows us to provide excellent care to our patients who struggle with this. And as a little bit of proof that we all really do love each other, we gave a joint panel at the American Cleft Palate Craniofacial Association meeting in Denver last year, and it was very fun. So when kids come into this clinic, they all go through, the same evaluation. Certainly, we look closely at their post-adenotonsillectomy PSG, but I also focus a lot on what is the main parental concern. That's such a crucial question because sometimes families are coming in with concerns that we may not be able to fix by addressing their sleep apnea. So it's helpful to know what they want to change. We also systematically collect symptom and sleep questionnaires to understand, along with input from the history, how symptomatic are they? And we don't just treat the number on the PSG, and they don't all need treatment. Certainly also a wake exam with a particular focus on the nose is very helpful. And where I also do a wake flexible laryngoscopy whenever I can get away with it. And often they will also have some imaging in the oral surgery clinic that could be a Ceph or a cone beam CT. And we really talk through all the options with the families. We talk, not just surgical. We talk about trying PAP or retrying it, try to facilitate, mask refitting or desensitization therapy where we can, consider maxillary expansion. It's awesome to work with an orthodontist who can do that for kids that are candidates. And then also we will automatically start medications if we think they're appropriate or helpful. I wanted to mention that my sleep medicine colleagues have taught me a lot about reading polysomnography beyond just zooming in on the AHI. And it can really give clues to the severity of OSA and guide management. For example, always looking at, was it a quality study? If the sleep efficiency is less than 70%, you may not have gotten a great snapshot of that child's sleep. Also, is the nasal signal poor? So a common scenario is you'll have a child who has hypotonia, cerebral palsy, is a mouth breather chronically, was mouth breathing through the study, but the flow is measured at the nose. And so their AHI might be mild, but the description of their sleep suggests that they probably have much more than mild sleep apnea. And so the study can undercall sleep apnea if the nasal signal's poor. I mean, same with, kids that are really congested on the day of the study. Also, was there a very high REM AHI? Is there hypoventilation or oxygen desaturation going on? And then there are, some children have positional OSA. So this is where the AHI is twice as severe supine than non-supine, and that can give clues to the pattern of obstruction. So this was a study that I did in a cohort of 99 kids who had post-adenotonsillectomy DICE. And we found that those with positional sleep apnea on their sleep study were more likely to have a high degree of obstruction, both at the velum, the palate, and the tongue base. So nothing surprising, but it's interesting to see, the numbers. And so, if they have positional sleep apnea on the sleep study, they're very likely to have tongue base or palatal collapse is really what that showed. Awake endoscopy also is really, I find this very useful to diagnose non-dynamic obstruction, things like adenoid regrowth and lingual tonsil hypertrophy. But I also think that we can get clues to the dynamic sites of obstruction that might be more prominent during sleep by looking for things like a long soft palate or a tight retroglossal airway or epiglottic prolapse while awake or arytenoid redundancy. And also, it's so valuable for surgical planning. It really allows parents to see the airway. They get a better understanding of the structures that we might be operating on, and it really helps with counseling. And for the past 6 years, we've been grading our awake endoscopies with this scoring rubric here. Right now it has face validity, but it's not validated, but I'm working on this. I started with asking how well the awake endoscopy score correlated with the sleep endoscopy in the same patients. And so this is data from a paper that will go in soon, but these are ROC plots with sensitivity on the y-axis and 1- specificity on the x-axis. And so a higher AUC number, my pointer's in the wrong place. Higher AUC number here means higher agreement between the awake and the sleep endoscopy. And we found that awake endoscopy has the highest predictive value for, not surprisingly, adenoid regrowth and lingual tonsil hypertrophy, but also a not bad agreement for sleep state laryngomalacia. So if you see a lot of floppy redundant tissue while awake, it's more likely that that tissue is going to be prolapsing into the airway asleep. So I mentioned DICE a couple times, but I'll just talk a little bit more specifically. So nearly all of the patients who come to the refractory clinic undergo a diagnostic drug-induced sleep endoscopy. And I position patients supine with no headrest or shoulder roll. I do occasionally use a nasal cannula on low flow to get them through the DICE without desaturation. I like a flexible suction available. I like to stand at the head of the bed because it allows me to control the airway and manipulate the jaw and head position. And I generally assess from the nose to the vocal cords. And that basically, the diagnostic yield of tracheal assessment is very low in studies, less than 5%. So unless I'm suspicious, for something, I won't do a bronchoscopy. And this spares us needing to use topical lidocaine in the airway, which can impact DICE findings in little airways. And it avoids laryngospasm and makes the whole thing safer. So this was a consensus statement that the Academy put out in 2021, specifically on pediatric DICE. And the group agreed, the indications primarily are for persistent post-adenotonsillectomy OSA, but that it can be useful and also in surgically naive kids before adenotonsillectomy, who have small tonsils or other risk factors for AT failure, but really thought it has limited utility at this time for the sleep disordered breathing OSA, child who has tonsillar hypertrophy. And the group identified also some points of controversy where there's no consensus and areas where there's a need for more research. So it's still unknown whether DICE performed at the time of adenotonsillectomy in children at risk for persistence is helpful, predictive, or improves outcomes. So it kind of goes to indications. Research still needed to determine an optimal sedation protocol. And also they mentioned a nationwide adoption of a standardized, sedation protocol, and also a grading system for DICE would allow for, more advances in DICE research. So speaking of scoring for pediatric DICE, so there are no fewer than 7 published studies in the literature, 7 published scales in the literature for kids, and none are really superior to another, and it was kind of getting out of hand. So we finally got all the DICE nerds together in a Zoom room and released an IPOG consensus statement on, the levels that we thought should be included, the patterns of obstruction we thought it would be helpful to include, and also the grading rubric. And we validated this new consensus scale in a separate study that we published last year, and we're kind of trying to push this and disseminate it as best we can. Although I admit I get emails, automatic emails about new DICE papers, and there was one that was published like last month, a new scoring scale in DICE, and I was just like, I can't even bring myself to read it. I will, but it was a little disheartening, but you can only do so much. So anyway, so back to the controversies. Number 2 was, what is the optimal sedation protocol? Kind of people tend to divide up into 2 camps. They like propofol or they like dexmedetomidine. And there's pros and cons to each. This group said that either can be used at this point. We don't know which is better, but did counsel that inhalation agents should be discontinued for the diagnostic portion of the study. So they have to be used for induction in general, but probably not great to do a DICE just on inhaled anesthetic alone because it really increases collapse of the upper airway. So I've really, been interested in this question of, does the choice of anesthetic make a difference? This was a survey, where surgeons said that about 58% of them use propofol, 50% dexmedetomidine. This overlapping number suggests that some use both. So I call that equipoise. So in an attempt to maybe provide some data to settle the controversy, I applied to look at this and got some NIH funding. So I've been enrolling patients for a randomized trial to receive either propofol or dexmedetomidine for DICE performed just prior to adenotonsillectomy. And we've been doing this for the past 3 years. I think we have hopefully 1 more year of recruitment. And we're comparing obstruction scores between the 2 groups, but also looking at the predictive value for adenotonsillectomy success. So stay tuned for results of that in the coming years. We're also at Michigan actively enrolling for another recently NIH-funded trial called TOPS-DS, and that's the treatment of obstructive sleep apnea with personalized surgery in children with Down syndrome. So Michigan is one of 6 sites nationally. Derek Lamb at OHSU is the main PI, and we're comparing adenotonsillectomy versus personalized DICE-directed, DICE-assisted surgery in kids 2 to 17 with Down syndrome who have mild or greater OSA, and they're surgically naive, at least they cannot have had previous tonsillectomy. And this is just a little overview, but basically we're doing, they have PSGs at baseline, symptom inventories at baseline, and then they follow 6 months later, and we repeat all those measures. And we're looking primarily at the change in obstructive AHI, but also at sleep-related quality of life, and then collecting a bunch of other secondary outcome data. And then we actually got funding to do, essentially almost an identical study in children with small tonsils. And right now, this is just a 2-site study. So I'm a multi-PI with Dr. Lamb in Oregon, and we're just starting to recruit for this study. So kids of a similar age range without tonsillar hypertrophy. So they can have Brodsky 1 or 2 plus tonsils, moderate OSA in this study, no previous tonsillectomy, and they have to be generally healthy. So again, hopefully we will understand from these studies, what is the utility of DICE? Should we be using it up front, or should we just be taking out tonsils and adenoids in all comers, no matter what? In the last couple of minutes here, I just wanted to talk about hypoglossal nerve stimulation in kids. The FDA approved this for use in children with Down syndrome, age 13 or older, who have an AHI between 10 and 50. So that's severe, but not super, super severe. They have to have had their tonsils and adenoids removed and either have an inability to tolerate or have failed CPAP. And then we still use DICE as part of candidacy. So we're looking for a non-concentric retropalatal obstruction pattern. So basically what that means is this person would be a good candidate, sorry about that, too many clicks, stable lateral walls on DICE at the palate. This patient is still a candidate with partial lateral wall collapse, but this patient who has complete lateral wall collapse would not be a good candidate for hypoglossal nerve stim. So, essentially from early trial data, the 12-month response rates defined by a greater than 50% decrease in the AHI was 66%. So about as good, if you look at any studies of sleep surgery, secondary sleep surgery in kids or adults, you're getting about 2/3 success. So it's in keeping with that. There's some early data to suggest that it can improve neurocognition and behavioral scores in kids with Down syndrome. A lot more studies needed there. This paper demonstrated that there's decent long-term stability, at least in this very small study of 4 kids. We now have a program. This is part of our refractory sleep clinic program now. We're offering this to kids with Down syndrome. I've done 4 implants in the past roughly year, and it's really picking up with referrals and a lot of kids in the pipeline. And this is just my first patient. So an 11-year-old with Down syndrome who came in with severe OSA and a low oxygen nadir, not horrible, but and was CPAP intolerant, interestingly with pretty severe autism, was non-obese, and was implanted successfully. Surgery went very well. I was very relieved. And then followed up though with the two-month post-op activation PSG. And with the device off, the AHI was severe, but turned on, it was essentially, the AHI was 0.7, meaning it was fully treating the sleep apnea. But the thing that is most important to me is this child has good nightly use since implant and is able to tolerate having it on for 9+ hours a night. I want to leave time for questions, so I'll kind of zoom through this, but there are some special consideration for this device in kids, that we have to think a little bit more about than in adults, particularly, risk of wound picking and infection, et cetera. And I think the interesting thing, that we're going to probably see in the coming years is expanded indications. So there's case reports of successful implants in younger kids, kids with, or actually adults with cerebral palsy. I think it probably will start to be used, and I've heard of cases of it being used for children with other conditions besides Down syndrome. This was a patient that had success, who had Treacher Collins. So I think I'll stop there, and thank you so much for your 30+ minutes of attention, and I'm happy to answer questions.
Thank you so much, Dr. Kirkham. That was incredible. I feel like we got like a